To give everyone a little bit of background, our project was to do an evidence-based research project. And because you just heard my specialty is in outpatient endoscopy, I wanted to focus on colorectal cancer. Colorectal cancer is actually the third leading cancer in the United States. There are several kinds of screening tests for it that can detect it, and one can actually prevent colorectal cancer as well. A colonoscopy, which is what I do primarily, is a procedure that directly visualizes the colon. During a colonoscopy, the GI physician or colorectal surgeon can also find and remove adenomatous polyps, which can be precancerous. When these polyps are removed, the chance of that polyp ever turning into cancer is also removed. And so colonoscopy is the one test that can prevent colorectal cancer. Another test is a flexible sigmoidoscopy, which is similar in nature, although only the bottom third of the colon is directly visualized. And thirdly, a fecal occult blood test, where a patient uses a kit at home to essentially put samples of their stool on a card, which is usually mailed in to a doctor's office, where they look for blood that is not visible with the naked eye. And currently, only 56% of African Americans are current, up-to-date in their screenings in one of these modalities as recommended by the American College of Gastroenterology. Men have a 30 to 40% higher incidence and mortality with colorectal cancer, which is why I chose to focus on this population. The guidelines from the American College of Gastroenterology suggest that screening for average risk adults begin at age 50, but because of the higher risk in African Americans, their screening age should begin at the age of 45. And patient navigation was the intervention that I chose to focus on and study. And you might be asking yourself, well, what is patient navigation? I also had to research it and find out myself too. It's an intervention that was originally used for patients as they were navigating through breast and cervical cancer screening, and it recently has been studied more with colorectal cancer screening. It essentially involves pairing someone, a navigator, with a patient to do things like telephone reminders, provide counseling on barriers, and also helping them schedule their actual procedures. Barriers to colorectal cancer screening have been widely studied. They include several things, most being a lack of knowledge about colorectal cancer. Patients don't know that they're at a risk or that they're at a higher risk, depending on their family history or genetics. Patients also have a fear of tests, mistrust of doctors. For most colonoscopies, people are given sedation, so they're being put to sleep. Patients have a fear of that. There's also issues with cost, access, and ease of scheduling, as well as the lack of physician or practitioner recommendation to have a screening test done. So my PICO question, my research question was, in African American men, does patient navigation as an intervention increase colorectal cancer screening rates? I did an exhaustive literature search using CINAHL, PubMed, and the Cochrane Review. My search terms are listed here: colorectal cancer screening, African American, colon cancer screening in men, and I had some inclusion criteria. I only included articles that were published in the last 5 years. At least 50% of the population studied had to be African American. Men had to be included in the study. The studies were based on ages 45 and over, and they were intervention-based. So an intervention was done, and that was looked at in order to see if colorectal cancer rates could be increased. Overall, I reviewed 37 abstracts, and I included 8. I did also only include articles that were published in English. So here is a summary slide, which I won't go into every one, but I found 8 articles that really met all of the inclusion criteria. 2 of them were systematic reviews of other randomized controlled trials, and they found that tailored patient education along with patient navigation can increase colorectal cancer screening rates. Additionally, the interventions are most successful when they are, again, tailored, when they address barriers and use multiple strategies for the patients. There were 6 randomized controlled trials that I found also. A couple of them were similar in that patients were randomly assigned to either a peer navigator or a professional navigator. So a peer navigator is someone who happened to be African American and wanted to learn about colonoscopies. someone that had a colonoscopy and was willing to be trained in order to communicate with patients. Professional navigators were not health professionals necessarily. They were people typically with at least a bachelor's degree. Some of them were healthcare related, but they weren't necessarily clinical like a nurse or a physician. They also were volunteers in these studies to be trained. But both of the studies that I looked at found that both peer navigators and professional navigators were equally as effective in increasing colorectal cancer screening rates in the population. There was no statistically significant difference between the two groups. And in the study groups, there was a range from about 70 to 85% of the patients who had those interventions got the screening, whereas nationally, if you remember, it was only 56%. Another one of the studies used a web-based aid, and they used this aid to help patients decide between colorectal cancer screening tests. So although colonoscopy is a gold standard, there are patients who refuse to have a colonoscopy because of a lot of the barriers that I spoke about. So this web-based aid allowed patients to interact and move between the different screening mechanisms and decide. And patients who use this aid were 5 times more likely to have a test preference. Now, there was no statistically significant increase in that group of actually getting screened, but with a pre and post survey, they were more likely to have a preference. 2 other interesting points I want to talk about. There was a study that provided patient activation, which is a term that I also had to look into. It's very similar to navigation in that it also provided barriers counseling and screening information. But the patient activation part was that it encouraged patients to talk to their doctor about the screening test. They were encouraged to bring up to their physician, whoever they were seeing, their primary care provider, about the screening. Patients who received this patient activation piece, which again did include the barriers counseling, were more than 2 times more likely to get screened, and they were 3.4 times more likely to have a test ordered. So if the patient is helping remind the doctor to get the test and that they need it, they were more likely to have the test ordered. Lastly, I want to touch on this Faith in Action program. That was one of the studies that I looked at. It was a culturally based direct intervention, and it was targeted at African American churches and community organizations. And the Faith in Action program was faith-based. It had some biblical references. It also used storytelling and open dialogue in order to communicate with the patients. And people who received this program versus the screening information only, and later they were offered the same program, they were 7 times more likely to get a colonoscopy. So with this plethora of information, I came up with some clinical recommendations. Patient navigation for African American men should include culturally specific patient education. So a lot of the articles that I looked at had key pieces about being tailored or culturally specific information to the population. The barriers counseling from another African American navigator. All of the navigator studies, whether they were peer, professional, or standard, did use African American navigators as well to communicate with the African American patients. There was one study that looked at minorities, and the navigator that they used was Latina. And the Latina patients in that study did have a higher rate of colonoscopy screening rates. So the clinical recommendations are, again, that you should use an African American navigator for African American patients. Telephone reminders were successful in all of the studies, as well as multimedia strategies. So print plus a telephone reminder plus a web-based or video aid. And of course, there are some barriers to implementing this. First, that always comes to mind is cost. How much would it cost to get these navigators, to train them? The cost of the printed material or the videos or the technology to provide the web-based aids in office. How much time it would take to train navigators, and if practitioners, physicians, NPs, or PAs want this to be done in their office with their patients. The cost of printed material, it is my idea that with the big organizations like American Cancer Society and Colon Cancer Alliance, providing this information free of charge for offices to use, or offices have a lot of handouts that they give to patients anyways. If it's readily available, that could be easily done. Because peer navigators were equally as successful as professional navigators, Volunteers could be used to be the peer navigators. People who want to give back to the community. People who have had a bad experience themselves with colon cancer or someone in their family. People who are just willing to get involved. Or people who are willing to get involved with people in their own church or community organization and be a navigator that way. So some practical recommendations to implementation would be for primary care offices, clinics, to use either a video or web-based decision aid before the visit with a primary care provider. So while the patient is in your waiting room, waiting to see the doctor, they can use this information to at least start talking about colorectal cancer screening. They can get more information about colonoscopy. If there's no way they're going down that road, they can get information about fecal occult blood tests, flexible sigmoidoscopies, or other options. Having this information before that visit would encourage discussions between patients and their practitioners and hopefully lead to more tests being ordered. The navigator would be assigned to follow up with the patient within 1 week post-visit, so the patient has some time to think about it, to think about if a colonoscopy was ordered, if they're going to go through with it. That navigator can then help schedule the test. And I would recommend direct communication from the navigator to get that patient scheduled to a test. And I'll give you an example. I work at a fairly large practice. We have a call center that does scheduling for 3 endoscopy centers, 6 doctor's offices, and 2 hospitals for outpatient endoscopy. I'm the center director for 2 of the centers, and I don't even know all of the people who work at the call center. But if practices can build referral bases and open doors of communication so that navigators know that they're going to call Francis, for example, who is one of our call center people, that they know that they're going to call Francis and Francis will help their patient get in to get scheduled, that may be beneficial to the patients as well in opening this communication. So in conclusion, patient education is key. In all of the interventions studied, they provided education and information to the patient. It can be done by non-professional navigators. It doesn't need to be clinically based necessarily. And addressing the barriers that individuals have for themselves can also facilitate screening rates. Thank you. And that's all I got.
The floor is open for questions.
Yes.
So in the study, did you find that the navigators were not hired, but from the primary care doctor's office?
Yes. It was not from the GI perspective. It was all primary care-based offices or clinics.
They would have referrals to the...
Correct. Yes. Yes.
You recommended that there should be care navigators as volunteers. Where do you foresee those volunteers coming from?
It's a great question. The one article that listed the Faith in Action program, I think people recruiting within churches or community organizations may be more likely to want to volunteer. Free clinics in the city may be able to get volunteers. There would certainly have to be some outreach there. And that is, I think, one of the big barriers. But my hope is that it would be easier to get volunteers. And I think that people who have had either personal or familiar experiences with colorectal cancer are much more likely to want to get involved and do what they can to make a difference.
Any other questions? Thank you very much.
Thank you.